Hello, everyone, and welcome to the NJAAP HPV Project ECHO Cycle 7 Tele-ECHO session, HPV Vaccine Effectiveness and Safety, presented by the American Cancer Society. This virtual clinic is brought to you by the NJAAP through a cooperative agreement with National AAP. Before beginning today, I would like to go over some housekeeping. For educational and quality improvement purposes, this Tele-ECHO session will be recorded. By participating in this session, you are consenting to be recorded, and to protect patient privacy, please do not provide any PHI information throughout the webinar. If you have any questions at the end of the presentation, please email me or Michael at mweinstein@njaap.org or jsatmary@njaap.org. Please make sure that throughout the webinar or throughout the session, you mute your microphone when you are not speaking. For your computer, the microphone is located to the lower left of your screen. And if you are logging in via telephone, please press *6 to mute and unmute. Please communicate clearly during the session, speak clearly, and use the chat function to send any message for particularly to the NJAAP admin account that is on this session. Do not put your phone on hold. If you must leave the meeting, please log out. We will hear hold music if you put us on hold. So now, before moving forward, I would like to conduct a quick roll call of all the practices to see who's on board with us. If you are not connected via audio yet, please send a message over the chat function so that way we can confirm your attendance. Advocare West Deptford, please announce if you are here.
Yes, Dr. Mishik's here.
Hello, Dr. Mishik, how are you?
Good.
Hi, Bandana Raha is here.
Hello, Dr. Raha.
Hi, how are you?
And I believe I saw Dr. Canesta and Dr. Hung online.
Yes, I'm on the line. I'm sorry, I was trying to unmute. Sorry about that.
Perfect. Chestnut Ridge Pediatrics.
Hi, Larissa Pilmar. Stacey is joining me in a second, and I think Sarah Lupu is going to call in. I don't know what's going on with Michelle. I think she's calling in as well.
Okay, thank you. Cooper Pediatrics. Okay. Dorothy B. Hirsch.
Can you hear me?
Yes, we can, Dr. DeBellis.
Okay, great. I'm having some technical difficulties. Okay, as long as you can hear me, I'm here.
Awesome. Future Pediatrics. Dr. Rashid, Dr. Noreen, I think I saw you send a chat, so I'm just going to assume that you don't have an audio connection.
Yes, Future Pediatrics here. Dr. Ami is here. Hello?
Yeah, we can hear you.
Future Pediatrics. Yeah, Future Pediatrics is. Can you hear me?
Yes, we can. All right, we have you down. Dr. Raha? Yeah. Thank you for introducing yourself earlier. And Rainbow Pediatrics. Okay. And the Rutgers Medical Group? Okay. And then we have Summit Medical Group and our Warren County.
Dr. Singer's here.
Hello, Dr. Singer. How are you?
I'm okay. Dr. Rogers is on vacation, and I believe Dr. Suma's calling in.
Perfect. Thank you.
You're welcome.
And then we have Summit Medical Group in our Westfield district.
I'm here, Michelle Bender. I'm not sure about the others.
Okay. All right. Well, thank you very much for that roll call. I would now like to introduce today's presenter. It is Debbie Saslow, who is the Managing Director of HPV and Gynecological Cancers at the American Cancer Society. So from this point on, I will turn the presentation over to Dr. Saslow. Dr. Saslow, you are free to begin.
Great, can you hear me?
Yes, we can.
Awesome, hi everyone, thanks for having me. So I'm going to be talking to you for a little while about the effectiveness and safety of HPV vaccine. And when we talk about the effectiveness, we need to change how we look at our outcomes with time. So the HPV vaccine is going to prevent 6 different cancers. However, it takes decades for an HPV infection to cause cancer, and most of the cancers occur in mid to later life. So if you're going to vaccinate, hopefully on time at age 11 or 12, it could be 30 years before you start to see the cancer incidence go down. We don't like to wait 30 years to know if our vaccines are effective, so we have early and mid outcomes. The early outcomes, the first thing we saw was an immediate drop in the prevalence of HPV infections, followed soon after by a dramatic drop in genital warts. So that only took a year or two to be able to see. Soon after that, we started to see drops in cervical precancer, CIN, based on cervical cancer screening. We do not screen for the other 5 HPV cancers. We have a little bit of data on anal precancers and vaginal and vulvar and penile precancers, but we don't we don't know about any precancers for pharyngeal cancer. So I'm going to show you first the early outcomes, then the mid outcomes, and a little bit of preliminary data on the late outcomes. So first I'll start with efficacy. This is a little different, or a lot different, from effectiveness. So this is, does the vaccine work in a clinical trial where you choose who is in the clinical trial? You get to choose only people who have not had an HPV infection before, and you choose only to look at people who get the vaccine at the age you tell them how many doses and get to follow up. But the clinical trial efficacy was extremely encouraging. You probably know that there are a lot of vaccines out there that are not 100% effective. Think about the flu vaccine and how some years it's pretty good and some years not so much. So we had a good starting point. Then once people started getting vaccinated, we were able to look at population data of HPV infections. And we looked at this in 2 different age groups. So in the 14 to 19-year-olds, we saw a steep decline in HPV infections. And then in the 20 to 24-year-old, we also saw a big decline, starting at a higher number because HPV infections peak in the early 20s. And then a little bit less of a decline because especially in the early vaccine era, if you're vaccinating and I'll show you this in a few slides from now, if you're vaccinating late, if you're vaccinating at that catch-up age, 17, 18, 19-year-olds, it's not as effective. And so you're not going to see it prevent as many HPV infections, genital warts, or cancers. But once you get to that later vaccine era, these 20 to 24-year-olds in the light blue bar, they had time to be vaccinated 10 years ago. And so you're going to see a mix of people who were vaccinated at different ages and better effectiveness. So now let's go on and look at genital warts. In Australia, they had much faster uptake of vaccination of females than we did in the US. So almost immediately they reached 70% or higher vaccine rates. And almost immediately they saw a 90% decrease in genital warts. That is in the females that were below 21. If you look at as a comparison in adult females, the genital warts numbers actually went up. So this is truly a direct effect of vaccination. Now let's turn to cervical lesions, to CIN2 plus and CIN. Yeah, this is CIN2 plus. Now, this one is a little bit misleading, that first age group of 18 to 19-year-olds. You see almost zero CIN2+, but part of the reason is because we changed the screening guidelines and we don't screen before age 21. So you wouldn't expect to see cervical lesions even in unvaccinated females. However, if you look in that 20 to 24 group, you do see a dramatic drop in CIN2+ across the female population, even though our numbers in vaccine uptake are much lower than countries like Australia. And as with the genital warts, if you look at the older age groups, you see that CIN2+ numbers are actually up. So again, this is directly the vaccine that is showing its effectiveness at protecting against advanced precancers. So that was all population data. In Scotland and a few other countries, such as in Scandinavia and now Australia, they also have registry data, so they can look at each person and they can see for a person who was vaccinated compared to a person who was not vaccinated. Now the years on this are a little different. This is date of birth. And so a woman who was born in 1988, when she turned 12, that would have been, okay, I'm a little confused here. These are women who were 11 to 12 in these ages. They were born in 1988. They were vaccinated in 2006 or later. And so you can see that in the pre-vaccine years, the blue line is before vaccination and continues on past 1990 when these girls did not get vaccinated. And this is their rates of CIN3+. Compare this to the gold line. So here, when these women reached the age of vaccination and vaccine was introduced, their numbers of CIN3+, 10 years later, that's where I got mixed up. There's another 10 years in there because they went from age of vaccination, somewhere around age 12, to age 21 when they got their first screening test. And so that's when you saw that CIN3 rates were going dramatically down in women who were vaccinated 10 years earlier compared to women who were not. And so you see 89% effectiveness. Now keep in mind that the first women, the first girls who were vaccinated, the only vaccine available were vaccines that protected against types 16 and 18, which cause about 70% of precancers. It wasn't until several years later that the 9-valent vaccine became available, and that prevents about 90%. So this vaccine is more effective than we expected it to be. Now, if you turn to cancers, that's the ultimate endpoint that we want to prevent. Now, as I mentioned, it's going to be a long time before we have good numbers on cancer, before we can really see 50-year-old men who are no longer getting oropharyngeal cancer, 40 and 50-year-old women who are no longer getting cervical cancer. However, from Finland, we do have a sneak peek, and we see that in the vaccinated women, so a lot of countries only vaccinate girls, not boys, there were 0 cancers, and you compare that to 10 cancers, mostly from the cervix, that occurred in the non-vaccinated women. And so we are seeing some effectiveness. It's very preliminary, but it is there. We are, as a public health community, for decades now, we have been 100% certain that if you prevent advanced precancer, advanced CIN3+, you will prevent cervical cancer. There is not a doubt here. You can prevent genital warts and not be sure you're going to prevent cancer. You can prevent CIN1 and not be sure that you're going to prevent cancer. But if you prevent CIN3, you are preventing cervical cancers. So it'll take a while to give you numbers of cancers, but be completely confident that this vaccine is effective close to 100%. So I've mentioned a couple times about the age at vaccination. I know that particularly when this vaccine first came out in the United States, providers were much more likely to vaccinate older adolescents than younger and that's for a couple of reasons. One, they thought it would be easier. They thought parents would accept it. They had this perception that parents didn't want it when they got their other teen vaccines. But now we have data, and it took a while again to get this data, because when kids were first vaccinated at age 11, 12, you didn't know that it was going to prevent CIN3+, because screening doesn't start until 10 years later. So the vaccine has now been out since 2006, and we've had 13 years to look at it and to look at those first women coming through screening who were vaccinated on time. So we now have data going back to age 12. And what this shows is that if girls are vaccinated at 12 to 13, and we have more data on girls than boys because we started vaccinating girls before boys. If you vaccinate a girl at 12 to 13, then when she comes in for screening in her early 20s, you have data, you have evidence that that vaccine prevents 86% of advanced precancers. If you wait a little while and vaccinate that girl at age 17, it's now 50% effective. And we also have data from other studies that if you vaccinate at age 15, it's somewhere in between 70%. For girls who were vaccinated at 18 or older, and those were girls who mostly were vaccinated at 18, 19, and 20, and then came in for screening at 21, this vaccine only prevents 15% of precancers. So if you are aware that the ACIP recently voted for shared clinical decision making for men and women ages 27 to 45, and the reason they didn't recommend it for everybody, and specifically noted when they voted that very few people will benefit and we don't know how to identify those people, think back to these numbers. If you vaccinate a girl at age 20 and it's only 50% effective, how effective do you think it's going to be at age 35 or 45? And since I think most of you are pediatricians, if you have a mom or dad in your office with little 12-year-old Johnny, and they say, well, I'll get these other vaccines, but HPV, I don't know. My little Johnny, he's going to stay a virgin until he's 40, and he's gonna marry a virgin, and they're never going to have non-consensual sex, and they're never going to have infancy. So I can wait and bring little Johnny in a few years. You can say to that mom or dad, if this were my child, I would prefer to protect them against 90% of cancers versus 15% of cancers. And I hope that they would be convinced to vaccinate on time. This vaccine does last. We've only had it, we've only been able to look at clinical trials for the last 20 years, so we can't say how long it's going to last, but we can say without a doubt that there are no indications that immunity is going to wane. And we can also say that HPV vaccines work similarly to other vaccines that offer lifelong protection without a booster shot. Still, there were people who were vaccinated as part of the clinical trials, mostly in all of the Scandinavian countries, who are being followed. And if they start to show an evidence of waning immunity, we can jump in and recommend a booster shot before it's too late. So you can be confident that this vaccine is extremely effective. You can be confident that the protection will last. And now I'll show you that you can be confident that this vaccine is very safe. In the US alone, we have multiple safety systems that will give us alerts if there is even the suggestion of a safety issue. In addition, there are similar safety systems around the world, such as for all of Europe and for the World Health Organization. And this gives you a glimpse of all of the safety studies that keep coming out year after year, ruling out an increased risk of any serious side effect that has even been suggested. So venous thromboembolism looked at over 1 million women, no increased risk. Multiple sclerosis, no increased risk. Autoimmune disorders, no increased risk. 60 other conditions, no increased risk. And if that hasn't convinced you, 109 studies, 2.5 million people, and 6 countries have all shown no serious side effects other than what's typical for all vaccines, which is the low risk of an anaphylactic allergic reaction or teens faints. Teens faint at the needle, teens faint getting any vaccine, and that's why for HPV vaccine and all others, we tell these kids to sit for 15 minutes before leaving the office. But other than that, no serious side effects. I hope that this is much more compelling than the one story that one of your patients saw on Facebook. In conclusion, this vaccine works, protection lasts, this vaccine is safe, and also this vaccine prevents cancers. Thanks, I'm happy to answer any questions.
That was great. Just have to say that. That was a great presentation. Thank you very much.
Yeah, this is Ruth. I agree. Great presentation. It's been interesting this past month. Several of you have really been scripting and talking about cancer prevention. You're really focusing on that and seeing the impact that that's having with the parents and caregivers. You know, I loved Rainbow Peds, your team. You said you're telling your patients you're due for your cancer prevention vaccine today. I mean, great message. And others are using the graphics. Dorothy B. Hirsch, the graphics from last month, and I'm sure you'll use some of the ones from this month, incorporating those cancer prevention and safety messages and visual graphs. You reported that that's been really effective when you're talking to parents who otherwise are, kind of hesitant about the vaccine. So we're seeing the impact of those messages that you've been changing over the last few months.
Any other questions? Thank you, Ruth. All right. So then if we can continue moving forward, we can go over the data review.
Again, great presentation. Thank you so much.
Yes, thank you very much,
so here's the aggregate data for the 7th cycle. We have an increase in the number of records that were reviewed by all of you, and just the usual message. Thank you so much for submitting your data through KEDA on time. That's really greatly appreciated. We're at what I would consider kind of a plateau for initiation. But what I'm also seeing in your reports, in your case presentations and PDSAs, is that you're starting to test those patients who may be in a more special needs category, those who have identified that they have religious or other, even personal belief objections to vaccine, and you're tackling, using the message, doing this messaging with those patients, and that's something new for many of you. So I'm hoping, remember we only have a few more months in this initiative, so it really is an opportunity to use, if you're not already doing that, to do that, because I think overall we'll really see a boost up in the next few months. But I would like to say, the Future Pediatrics team, Jersey City, for the last 2 months, you've been maintaining 100% of the patients that you're seeing, you are successfully, you reported successful initiation of HPV. So great job with that. I was curious, some of you who have had an N that's been lower this last month, I don't know if the Cooper Peds team is on the call, but is it because more of the patients have already received or initiated their vaccine, so they're not eligible to be, and so you have smaller numbers who are still needing to start their vaccine and or finish it? So I was just curious if it's the smaller N's may be due to that or other things. Any thoughts any of you have about that? If you find that you haven't been able to find 10 patients in a month, is it because they're immunized, they're either initiated or completed?
That's what I would like to think. I think
okay.
We do a pretty good job of immunizing the ones that starting at age 11. I know we have not been successful, and I will be honest, we really haven't pursued this aggressively at starting the immunizations at age 9. So a lot of our cases, that are negative are because the child is 9 years of age and we didn't initiate the HPV vaccine. We're really pursuing more, doing it at age 10 because we can still bundle them with the Tdap and the Menactra. But we're not immunizing our kids at age 9. So I think that's a big group for us. But we are pretty good at getting the 11 and 12-year-olds. So.
Great. And that brings up a good point, that the other reason I think that this is kind of flat is that some of you, you're now giving the message at 10 and making families aware, but still some of you reported, that maybe only 30% of those will actually choose the vaccine at 10, but they said, oh yeah, when we come back at 11, we'll be ready to go. So that may be.
It's nice to be able to bundle the 3, and we just try to do as much anticipatory language as possible. Your child is due for the 3 vaccines, kind of period, and most parents just say yes. I'm actually surprised that people haven't really questioned, and when they do question, they say, oh, I thought they didn't need it until age 6, and we're just saying that's what the school requires, but actually we can give them as early as today, and we just figure the earlier the better, and most parents are actually very receptive to it.
Great, thanks for sharing that. Anybody else before we move on? Okay, next slide please. Okay, looking at completion, we've had a steady move upward. Great job. Again, I know, some of the N's from individual practices have been low, but a lot of these vaccines, the N in this past month were Chestnut Ridge patients, and you guys have done a great job with your completion rates. Of those patients that you reviewed this past month, almost 88% of them, higher than the aggregate number, have completed the vaccine that they were due for. And I think we're going to hear from Cooper Peds about how they're one of the PDSAs they've done to improve that completion rate, to make sure the patients are coming back in a timely fashion. So we'll do that in a few minutes. But Future Peds and the Jersey City pediatric team, Dr. Raha, the last 2 or 3 months, 100% of those patients that who needed to be completed, you did that. So I won't call it a trend yet with only 2 or 3 months worth of 100%, but you're great. I think there are systems that are being put in place based on the changes you're making. So great job. Next slide, please. Okay, missed opportunities also are kind of have moved definitely in the right direction. Again, it's kind of slowed a little bit, but I think that you're much more aware of the missed opportunities. Look at the number of patients that you're reviewing, to be able to only a little more than a third of a higher number of patients that you've reviewed. So let's look at the individual reasons on the next slide. Next slide, Jake.
Sorry.
Okay, so parents who have refused or declined, I'm not concerned about the bump up. Like I said, you know, it's probably random variation, not a trend. But just something to pay attention to. But I think that in this case, it's the fact that you're talking about this more often with 9 and 10-year-old patients. So they may have decided to, you know, they refused today. But like I said, you're having these important discussions with patients that you may have just said no, okay, when they refused or declined before. Future pediatrics, you know, you talked about a family who had religious objections, and you talked about cancer, and you were able to successfully immunize that child as a result of the discussion, opening a discussion that you didn't otherwise have before. You know, as I said, I think we'll continue to see that impact. Next slide. The postponed, again, you know, that's, you know, overall, other than, you know, baseline, where it's been kind of stable, little, some random variation. But again, not, you know, you're raising awareness, and I think that as these patients hit 11, and the fact that you're bundling your messages, we're going to see more initiation and then completion. Next slide. Continuing to do a good job, you know, contraindications are not a reason for missed opportunities, you get it. So that's been great. Next slide. And there's been the number that before you were calling other, you now have recognized as other a category like, you know, postponement or refusal. And so these are, you know, these are kind of, you know, there was, you didn't have it's often due to you still may not be offering the vaccine at a certain kind of visit, or they were there for a sick visit and they weren't well enough. So, you know, it really wasn't a missed opportunity. You categorized that as other, but may not have been a real missed opportunity. But if you are not yet talking about this as part of acute visits, or other types of, you know, physicals for sports and things like that, then these are, again, opportunities to start or finish vaccine series for HPV. Next slide. So before we move on, my message to you is you're all doing a great job. I like that. I hope that you'll continue, or you'll start to talk about this initiative and the work that you're doing at your staff meetings, in addition to the QI meetings you're holding. Chestnut Ridge team, you know, is great. You had at a staff meeting, you know, you talked about the initiative. You got staff input about to get buy-in, so that everybody's giving the same messaging about HPV. Any comments that you want to make about the impact of you know, really bringing this to everybody in the practice, so that it, you know, is that making a difference for you? You have to unmute if you. Okay, well, we can do this as part of the discussion. But just one thing to remember for your PDSAs, that's supposed to be real-time data collection. So if you, you know, did something differently today, at the end of the day, measure whether or not it's had an impact. Don't wait until your monthly data collection at the end of the month when you're putting your stuff in, your records in KEDA. That's not when you should be evaluating the PDSA that you did. So just a reminder that your PDSA can be the next patient that you saw. I mean, your data collection for your PDSA could be the next patient that you saw, and whether or not you were successful or not. So any questions about the data? Great. Okay, keep up the good work. To start us off, there was a comment, Dr. Mishik, I think it was part of your case report as unsuccessful vaccination opportunity because of the inability, the not being able to co-administer Trememba as well as HPV. And the question was raised, I mean, a few of us looked at the guidance related to Trememba and couldn't find anything that said that they couldn't be administered at the same time. Is there, you know, could you clarify if you...
It's not Trememba. It's, you can't do, is it Trememba? I thought it was...
That's what it was written in
it should be Menactra. Menactra is I don't think that you can give both the Menactra, which is the meningitis, the quad that's given at 11 years age, cannot be given at the same time. Hold on a second. I'm trying to think here. It is. Oh, that's what it is. You can't give both the two meningitis vaccines, both Menactra and Trememba, as well as an HPV at the same time.
Dr. Bishop, where did you see that? Because I've not heard of that.
I don't have my papers in front of me. Angela, are you on the line over there? Because I know that that's been an issue at our office that we have to pick between them. Dr. Kniestout? Hello? I thought she was online here.
Can you hear
me? I do know for a fact.
Can you hear me?
Angie, now we can. Yeah, now we can.
Okay, I'm sorry.
Angie?
It's Trememba that can't be given with it.
At the same time, correct?
Correct.
It's the fact that you have. No. That's not what I was saying.
I'm sorry. You broke in and out. I'm sorry.
I'm sorry. You cannot give both Menactra, Trememba, and HPV at the same time. In the literature, there is something in the thing that it's a contraindication, that it's not been formally tested with all three at the same time. That's part of the problem, and that's actually from the vaccine manufacturer.
Right, but in our patients where it, and when I wrote out the information, it's specifically, I realize it's beyond the age category that we are referring to in our study, but it's the Trememba that is not indicated, excuse me, it's contraindicated to be given with the HPV.
At the same time, correct.
We do at 11, obviously.
Right, Menactra we do, correct. But at 16 years old, when we do it again, and that's when the Trememba is first given. And if you're doing a catch and you're doing your second Menactra, you can also give Trememba and HPV. It's one of the indications why we should get the HPV vaccine done at 11, 12, and 13 as opposed to 16, 17, 18. That was the point that we were bringing up.
No, I agree with you. No, right. Like I said, it's beyond the age range of the study. It was just, and there are times, obviously, where our patients do delay it, as we've discussed multiple times. This is one of the situations where we potentially could give it, but we can't when we're catching these kids up. Obviously, yes, they're older and they're going to need 3 doses. I understand that. But that's just, I was just bringing up a situation that happens often enough.
No, we were glad that you brought it forward as a case presentation and for one of your older adolescents and raise that concern or that issue.
I'm still not sure whether it's contraindicated versus it hasn't been tested. And I think those are 2 different things.
It hasn't been tested.
I don't know that there would be harm. The question is, would there be harm, or would it just say, okay, maybe the immunity might not be quite as good because it hasn't been tested and we don't know? I'd have to.
I believe it hasn't been tested.
But I don't think that there's contraindication for this.
There's no contraindication, but if you administer the vaccine and it's not been approved in that manner and you have an adverse outcome, you're putting yourself at medical legal risk, is what it really comes down to. It hasn't been tested. And so you could have one kid in a million who decides that they're going to have some kind of unusual reaction, which we know happens all the time. Kids pass out and stuff like that. And unfortunately, these parents are, I mean, litigious to a degree, to an unbelievable degree. I mean, actually, we had a case a couple of years ago, within the last 2 years, where an 18-year-old got a vaccine at 18, was sitting on the table, big kid, about 6'2", 6'3". He had a syncopal episode after getting his shot, as is well known to happen. He fell off and he hit his head on the floor. And we wound up having a parent that, you know, despite the fact that one of us looked at him, they rushed the kid to the emergency room. There was nothing wrong with the kid when he left the office, just that he was a little wobbly. And then proceeded to, you know, bring up this whole issue about how we should pay for him going to the emergency room because we're the ones that administered the vaccine and it was our problem. And to be perfectly honest with you, what we wound up doing in that particular scenario was like, okay, give us a copy of the emergency room report and give us a copy of the bill that you have related to it. And lo and behold, as soon as we put that combination together, we got crickets in the background. We didn't hear a darn thing from them, and nothing ever came of it.
All sites I see, especially like on the CDC site, I mean, they clearly say that you can give all of the meningococcal vaccines with other vaccines on the same day, just at a different site. But I've never heard not being able to do it with the HPV.
When the when the Tremember was initiated, I know when I spoke to one of the personnel at an AAP conference, approximately within 2 years, they said that they were not approved to be co-administered. That's at that time. Now, I didn't believe things had changed. I didn't see any reports that are, if I'm wrong, I'm wrong, and I stand corrected. And by all means, if we can start administering it, then I would gladly do so. And maybe contraindication was too strong of a word. It was, like I said, it was not approved to be co-administered.
Can I say something? Just so you know, I'm on the CDC website. The CDC website says about the MenB vaccines. On the basis of available data and expert opinion, Bexsero or Trememba may be administered with Tdap, HPV, and the Menactra. If received during the same visit, clinicians should administer the vaccine at different injection sites if feasible. So it doesn't even say that you absolutely need to have different injection sites, just feasible. So I think you can administer them all at the same time. And that's right off the CDC website.
If I may interrupt for 1 second.
I appreciate that. Thank you. Thank you.
Just so that everyone's aware, we can still continue this conversation, but we've hit the 1 p.m. mark. So if anybody needs to leave at this time, they're more than welcome to. You can see the next requirements for the next cycle for data submission, case presentation, the next teleecho session. The post-evaluation survey has been submitted to the chat box. But if anybody wants to stay on the line and continue this conversation, they are more than welcome to.
Yeah, Angela, I would say, I mean, whoever was speaking that looked up at the CDC website, if you could just send us that link so that we could review that, I'd appreciate that.
Great.
Okay.
Good discussion, important one. Thank you. And thank you for bringing it forward when you were, you know, concerned about it.
Thank you very much.
Thank you.
Right. Have a good, anything else before we close? I think we're good. Thank you all.
Yep. Very good. Thank you. Bye.
Have a good one. Bye.
Please enjoy the rest of your day.
You too. Bye-bye.
Bye-bye.